Hi, I'm Helen Bauer, and this is the Heart of Hospice podcast. The Heart of Hospice podcast is your source for compassionate and informative discussions about hospice and end-of-life care. I'm a certified hospice and palliative care nurse with over 15 years of experience. Whether you're a caregiver, someone with a serious illness, or you simply need to know more about hospice care, this podcast is for you. Join me as we explore all the aspects of hospice, from the details of caregiving to the emotional and spiritual dimensions of end-of-life journeys. For more resources and to connect with me, visit theheartofhospice.com and find us on Facebook, Instagram, and LinkedIn. Keep listening for today's episode.
This is the Whole Care Network. Helping you tell your story one podcast at a time. Content presented in the following podcast is for information purposes only. Views and opinions expressed in this podcast are solely those of the host and guest and may not represent the views and opinions of the Whole Care Network. Always consult with your physician for any medical advice, and always consult with your attorney for any legal advice. And thank you for listening to the Whole Care Network.
This episode of the Heart of Hospice podcast is being sponsored by bkbooks.com. Barbara Carnes and her team at BK Books have created the Approaching Death Support Kit to help educate and support families with clarity and compassion. This new bundle is a practical, ready-to-use resource for the bedside and includes many of Barbara's most trusted booklets. For more information, visit bkbooks.com or see the show notes for the link to bkbooks.com.
Today's episode is a great conversation with hospice and palliative care advanced practice nurse Elena Prendergast. Elena Prendergast is a board-certified advanced practice nurse certified in hospice and palliative care. She's a healthcare leader and the owner of Tree of Life Health Consultants. In addition to her palliative care experience, Elena has training as an end-of-life doula. She's trained in functional medicine and trauma and resilience. She's dedicated to improving the healthcare experience, and that dedication extends to serving in her local community and on the national stage as a clinician, an educator, and an advocate. She's a natural storyteller, which you are going to hear from our conversation. She draws from her experiences to help her relate to her audience. You can find her work at treeoflifehealthconsultant.com. In our conversation today, Elena describes how she's been able to keep her work as a death doula separate from her work as a medical professional, and you're going to hear us talk about why that's so important. As a death doula, she encourages family caregivers to be an advocate for their loved one when there's an issue, and she recognizes that communication is super important in her line of work. She even shared some of her best practice communication tips, really helpful. Elena also shares the questions she doesn't like to ask her patients and the one question that she loves to ask. You're going to hear her talk about her most challenging case, along with the lessons she learned from it. Elena's skill and passion for her work really shines through in our conversation, so please keep listening. There's a lot to learn. Elena, welcome to the podcast. I'm so glad to have you with me. I'm super excited about our conversation.
I'm excited too. Thank you so much for having me.
I feel like we're going to get into some trouble. We've taken up 30 minutes just talking and kicking stuff around. And then we finally decided we'd go ahead and record because we don't want to miss the good stuff. So it's really going to be a great conversation. So we're going to jump in. I want to do a question just to get to know you a little bit. And of course, it's going to be death and dying and hospice related, right? Can you share one of your end-of-life wishes with me and my listeners? Oh, that's a wicked smile.
Well, I do. I have to laugh about this one because it's a story that was a couple of years ago, probably 2022. And my husband and I both had gotten COVID at the same time. I shared. I got it first. And I was on the mend. He was still kind of, in the midst of it. And all of a sudden the thought comes to me like, man, I should probably update my advanced directives,
Right.
And so I'm laying there, I'm kind of bored. And so I send a message to my children on text. Not a good idea. I said, I'm fine. Just I have a question. And so I asked them if something happened to dad and I, and he can't make decisions for me, which one of you would make the decisions, So I get, what the hell, mom? My oldest says, I can't decide what I'm going to wear. My middle's like, I will make whatever decisions have to be made. That's my planner. And my son said, I'll do what has to be done. Well, I said, none of you are making my decisions. And so
Good call.
my sister's actually, she's actually the person, but inside of there, in the little section where it says notes for everybody to know, and this is like total transparency, but this is who I am, right? And I said, I value dignity, above all things. And so I said, I would like to be turned every 2 hours. I would like oral care, and please do not allow facial hair to grow. So yes, that is
I love
my
it.
advanced directives. But I do use that with people to tell them, like, make it as personalized and as much as you can. And that's like the little secret, like menopausal women aren't going to talk about. And so all the
Right.
women I talked about laugh about it and go, you can put that in there? Yes, you can.
Yeah. If you got a little mustache and you bleach it or you wax it or whatever you do, yes,
Right.
don't let that grow on me.
Exactly.
Absolutely.
Exactly.
I love it that your kids had that response because mine were a little bit the same way. Their first response was, to joke about it. And I figured one of them's going to prop me up on the couch, have me stuffed or freeze dried. They're not responsible. I think I have a niece that might be a little more attuned to following directions, but my two kids, yeah, we call them the jokers because I don't think we're going to make it through. But yeah, the one that said, I can't decide what I want to wear that day, so I'm probably not your person. You got to admire the honesty, the self-awareness in
The
that.
funny thing is that's my oldest. So I'm glad she chimed in because they would think to look to her first, right?
Right. Well, and your middle child was the one that said, I got you. I can do whatever you need to
Yeah.
do. Now, I got to tell you, the
Mm-hmm.
third one's response is a little bit scary.
Mm-hmm.
Yeah,
Yeah,
like
that's
I'll
my
pull the
son.
plug 5 minutes after something
This is all
happens.
business. What business has to be done? I'll do it.
Yeah, I don't know. That's a little threatening. Oh, that's
But he's
funny.
my joker.
Yeah, well, so my sister, I have talked to her about my eulogy. I am not one of these people that wants a very flowery eulogy. Be real about who I was, that I cussed and I had a history of depression, all these personal things. It's okay to say all that stuff. I'm not a saint. Don't paint me like one. And I said that to my sister. I said, I really don't want my eulogy to be this sanitized version of my life. And she said, oh, don't worry. I'll make sure it's not. That was a threat. That was a threat.
All of those things.
Yeah, she was mean when we were kids. Okay, just saying.
That's awesome.
But yeah, I love these end of life wishes that are so personal because they are things to be thought of with a little bit of humor and maybe some nostalgia. When you start talking about the music, if you like music, and the personal things. Make sure my nails are painted pink, things like that. I love the personal side of things, and I love it that you have that in yours. So
Yeah.
we are going to move into the interview now that we know all about you and your kids. So you had been a nurse for a while, and you're a nurse practitioner. How did you move into end-of-life doula work? after working in a clinical capacity?
I'm still doing both, right? But I think what really made me consider that side of it is how many people had come up to me and said, I wish I could do that. And they were legitimately trying to understand, how do we hold vigil? How do we navigate? How do we support? But they're probably at an age or a point in their life, they can't go back to nursing school. They don't want to go back and be an NP or anything like that, because even nurses, like retired nurses, that were sitting there going, I don't want to go back and do that, but I still feel like I have something to offer. So I wasn't real familiar with the end of life doula role. I was familiar with a birth doula. But since I do always compare birth and death, like as these parallel, things that happen, I thought, well, why not? So I decided to explore that and see, like what's out there. What are people being taught that haven't gone through the formal training like we have? And what I found honestly was, it's what most of us do when we're not in a clinic, a hospital, whatever. It's what most of us do when our family members call us and say, I don't know what to do. How do I help? And that felt so natural. It was just giving a name to something that myself and so many other nurses and nurse practitioners do when they're not clocked in, or, on an actual case. That's really, I think, what drew me to it.
I love that. I love that. I think there are a lot of nurses who are working as hospice nurses and palliative care nurses who would like the luxury of an expansive practice where they can do that type of work, vigiling, companioning, when, of course, we're really restricted by time and productivity requirements, things like that. So when it comes to those roles, so I think it's important for listeners to understand that end-of-life doulas are not licensed. There's no regulatory organization. There's not a standardized required education. There are numerous organizations around the United States, actually probably around the world, who are doing end-of-life doula or death doula training. But it's not, in the United States, it's not licensed. Whereas in nursing, we are licensed, we're heavily regulated. There's a lot of monitoring. So we have to keep those roles separate. We have to keep the interventions that we offer separate. What are some of the challenges that you deal with in trying to separate those two? Do you ever get an itch as a doula to say, ooh, I know what medicine you ought to be taking. I can help you with that.
Absolutely. But I think because I'm so worried about blurring the lines, I'm very clear up front that what I'm here for is to help you navigate through the system that's in place. Generally, the system that's in place will be oncology or, whatever serious illness they have, and then hospice. A lot of times, and I know you're familiar with this, they need to get to the point where they trust somebody to speak to them about, I'm thinking about, and not feeling like they're committed. Right. It's kind of like the pre-work before we buy a car, right? And it's sitting down, discussing with somebody, what's important and these other things. You're right. Regulations, really regulate what we can say. And over, I say to people, it's a non-medical role. You have the benefit of the fact that I understand the system because I work in it. But if it comes to a question about a certain medication or anything else, I'm always going to defer and say, you need to ask your hospice or you need to advocate for your family member to have this, this, and this. It's not something they could not find on a Medicare website, right? About what their benefits are. The only difference is we know all of that stuff. They don't have to go and look it up. So I do try to be very, very clear all the time about, I'm functioning. The good thing is that I think people are so appreciative of just somebody breaking it down for them. I haven't had anybody ask me in any way to cross that line. Even I've done vigil work for family members. I haven't really done it a lot for just a client. And I have always been clear. I will not give medication I will not have any part of the medication, giving dosages, anything like that. I will show them how to advocate, for their loved one to be comfortable. And in that sense, but I don't think that that's not any different. We were talking earlier before we got on about the chaplain who notices a patient in pain, right? And
Right.
they report it back. No, it's not the chaplain's scope of practice to be in there assessing pain, but a person that sees grimacing or moaning, that's very clear. And that's where you can tell the family member it is time for you to call the hospice and advocate for your loved one.
Right. Do you think that the continuity of having somebody consistently who's knowledgeable, handing you the specialized, the specific information that you need, do you think that continuity helps? Because our system is so siloed. If you go from the hospital to home health, and then home health to your doctor's office, and then the doctor makes a referral to hospice, you're talking to all these different people. Caregivers or patients are talking to all these different people. Do you think having a consistent person to help them navigate through all these different pieces, do you think the consistency is helpful?
I do. I think people have reasons, whatever they are, to mistrust the system. We've seen there can be greed, there can be, disenfranchised people or anything like that. Whenever you have someone that has allegiance to you, you automatically are starting out in a place of trust. At least you hope so, right? You're paying this person
Right.
to provide a service to you. It's just like a lawyer, insurance agent, anything like that. You're thinking you're working for me. So in real estate, I did real estate before nursing, right? And you come in with your buyer agent and your selling agent. Well, as a buyer, you have your own agent because you're just like, I want my interest represented. And so I think it's the same kind of thing, having someone that can, so to speak, translate. Because a lot of the confusion, and also to be taking notes of things that we know a family member will brush over in a conversation with a physician or a hospice and swear it wasn't said or it was said,
Right.
or the conversations that you have with them and then they forget to have this conversation. I've been in rooms with people where I will remember that they wanted to know about this, that, and the other. I will wait until the whole visit's over. I will ask, can I bring up one of the questions that you have? And it's still up to them, whether I bring it up or not. And then I will ask the question so that it gets addressed for them. And then I'm taking notes. So sometimes, it's kind of functioning as a doula, kind of patient advocate kind of thing. But it is just helping them along that navigation, because when we get stressed, we know physiologically, like, things shut down. We don't hear, we don't process. And so I think having someone that's kind of navigating them through the whole system. I think when you think about the birth doula, right? The birth doula in no way will replace the midwife or the OB, but they are there with the mom to advocate and remind the team of what was important to that mother.
Right. A lot of it goes back to communication and advocacy. I mean, goodness
Absolutely.
knows that the healthcare system is broken. We know that people of color engage with it less for some very good historical reasons, right? We get that. But the system is broken for everybody. The people who work in it acknowledge that it's broken. I've been a nurse for over 30 years, and I'll tell you the healthcare system in the United States is jacked. I don't even understand my own insurance. Who really does understand those things? So having somebody who can at least, what I call, speak the language makes so much difference. I have found that the flow of information is like drinking from a fire hose for people. And when you add, like you're saying, grief and fatigue and financial stress, all the psychosocial, emotional stuff that goes with having a serious or a life-limiting illness, they can't hear half that stuff. They just can't take it in.
They're still processing. A lot of times they're still processing the diagnosis, or the prognostication. Most people go to healthcare because they think they're going to be fixed, healed, made better. And when you get a diagnosis that tells you that's not necessarily going to happen, they weren't prepared for that. No one really talks about that. And, we're in the business, we like to say, of giving people hope. And we look at it as having conversations about diagnosis and prognostication as kind of a failure or taking away a person's hope.
Right.
And my mindset is not having those conversations takes away their hope, because they don't have an opportunity to make any kind of plans or decisions oftentimes in an appropriate, length of time, because by the time they get told that they might have days to weeks, hours to days, whatever, to live, there's not a chance to make those decisions.
I love that you're saying that, because we really do deal with that. We don't want to take away people's hope. Physicians especially are really hesitant to give any sort of bad news about a diagnosis or life expectancy. And we worry about, robbing people of their hope, is the way I've heard it said.
Right.
So that's a really beautiful way of looking at it. You are actually giving people hope by giving them the truth about where they are. So there is time and there is space to process. And I know not every diagnosis allows for that, right? Not every
Right.
hospice patient has been sick for 7 years before they come to us, right? Some of them have had acute events that just happened yesterday. And yeah, the fire hose is coming for you in those situations. There's no way. It's like a wrecking ball that's going to swing at you and your family. But I really like that idea that we're actually giving people hope that way. So communication is key, and that is one of your passions. I even read this on your website, and we had talked about this when you and I talked before, especially with the hard stuff. You are that courageous person who will step forward and say the bad words, the D word, death, dying, all the hard stuff. How would you describe your communication style? And then I want you to share some of your best practices when it comes to asking hard questions. So how would you describe your communication style?
I'd like to think that my communication style focuses more on listening than talking. Um,
And listening is part of communication.
right. And so what I often tell people is I wear the white coat because I sat on the other side of the white coat. So I think because I had so much personal loss in my own life, the times that I wasn't told the truth, or the times that I felt disenfranchised and so many things, I understand. Sometimes they don't even understand what they're feeling, but I understand it because I'm on the other side of it. So sometimes I know that I'm going to ask the question that they haven't even thought to ask. So I think that that's a big part of it. The other thing is just being real, whether it's laughing, cracking a joke, whatever it is. People think that all of our conversations have to be somber, right? And that's not true. A lot of times, I've actually had people that cracked me up because I had a particular patient who I broke bad news to, and I was kind of waiting for it to drop. And he said, "Oh, hell." He said, "If I'd known that, I would have smoked more cigarettes and drank more beer." And I didn't expect it. But, that was kind of his response. And I just went with it and we laughed about it. But I think the key to communication is it's like dancing, right? Being a good follower, shifting when they want you to shift, not being so tried and true to whatever agenda you had in breaking bad news, whatever it is,
Right.
that you've got to stick to the script. I think when people see genuinely that you care, that you're asking questions that have to do, for me, it's all about quality. So the questions I'm going to be asking is kind of narrowing down what's that quality of life look like. That quality of life question is going to change, right? If we get prognostication that says you've got days to week,
Right.
and then we'll have a different type of question. As far as the best practice, my first and foremost is, like I said at the beginning, is to listen. The only person who's uncomfortable with the silence is us. They're comfortable with the silence. They've been sitting with it for a while. We need to sit long enough to let them process whatever question or whatever statement that we've made. Now, for those that aren't in the hospice and palliative care world, right? They're like, oh, well, how do I do this? Well, there's simple things. Even with my students, I tell them, just ask, tell, ask. You can use that for any single situation. So the first one is to ask them who they think you are, why they think you're there, and what do they understand about their diagnosis. Then tell them who you are, tell them why you're there, and then tell them the information that they need, and then ask them one, and I forgot the first ask them if they want to have the conversation. Sometimes people don't
Oh,
want to have that conversation.
yeah, good
So I
point.
think I should preface that. Ask them if they want to have that conversation at that time. Sometimes they don't, they just can't. And we need to respect that. And then the final ask, like I said, is, to ask what are they thinking? What are they feeling? What do they understand? And then ask them if they have any questions, or is there anything that you can do for them? So if you kind of guided your whole conversation by ask, tell, ask, and there's other acronyms, but to me, that's the simplest, the easiest. The guide is already kind of written in there, and you can kind of flow with them based on, having a loose structure. The other is to remember that they are not a number, they are not a chart, they are not a diagnosis. This is a person who had a life um, prior to getting to the hospital. And sometimes when I was in the hospital, I would go up to my families and apologize to them and say, I'm so sorry. All I know about your loved one is the diagnosis, when they got here, their labs, kind of what everybody's weighing in, but I know nothing else about why you're at this bedside. And I will let them recount kind of who this person is, outside of sickness. Now, for me, that accomplishes two things. It fills in so much information. But if the situation were to end up at a point where a family has to make a very difficult decision, a lot of times that's with stopping measures that are extending someone's life, and I'm not saying stopping treatment, but it's excessive treatments possibly, or even aggressive treatments. Sometimes you can use that information to remind them who that person was and what was important to them. And that helps them with processing the information. So for me, those are kind of the things that guide me when I'm talking to, patient, client, family.
Oh my gosh. There's so much I want to unpack out of that. So the first thing that strikes me is when you are asking about admitting up front, all I know is what's happening with your person medically right now. I don't know them. I don't know who they are as a person, as an individual. That empowers that family to maybe recall and share some of that. I think that helps to define values, because a lot of times that family doesn't have anything else to go on when it comes to making decisions.
Yes.
If there's not been a conversation, if there's no documentation of an advance directive, I have asked families, think about who he was as a person. What did he value? Was he a family person? Was his being active very important? Was he physically active and involved in sports? Things like that. Was it really important for him to be able to communicate and connect with family and friends, to be social? All of those things. Did he have an active hobby that he likes to participate in? And when you're looking at personhood, that's where you have to get those decisions from when there's been nothing documented. I really hope that there are some caregivers listening to this as well, because what I hear you saying is that you drew that out of the caregivers, and that's one of the ways they participate as advocates for their person. And so if you're a caregiver and you're listening to this episode, you have to know that we really rely on that. It's not our job as healthcare practitioners, clinicians, nurses, and doctors to know the intricacies of everybody's private lives, right? That's not why you go to your doctor, to let him know that you've been crocheting for 10 years and you made a baby blanket. That's not what their area of expertise is. But when it comes to knowing who you are, your family's the expert. And they are the people bringing that information. So if you're a caregiver and you think that information's not valuable, oh man, it is so valuable to us. It's vital to the care we provide. It doesn't have to be a medication.
Absolutely.
Yeah, it's not a reason for giving you a consult to nephrology, but it really does sort of undergird or create a foundation for all the care that we provide. All of it. So I think those are such important best practices. I love that you shared that. I hope you're enjoying this episode. We're going to pause for just a minute. My guest has more to share.
The sponsor for this episode is bkbooks.com. When someone you love is dying, the journey can feel overwhelming. What do you do? What should you expect? How can you help? Barbara Carnes, RN and end-of-life educator and hospice pioneer, created the Approaching Death Support Kit to bring clarity and practical guidance to the bedside.
Hi, this is Helen, host of the Heart of Hospice podcast. As a hospice nurse, educating the family has always been a top priority for me. The Approaching Death Support Kit from BK Books provides families and caregivers with clear, practical guidance to help them navigate the end-of-life journey with confidence and compassion.
The bundle includes many of Barbara's most trusted booklets, Gone From My Sight, By Your Side, The 11th Hour, Pain at End of Life, and her newest title, Always Offer, Never Force. Whether you're a nurse, social worker, chaplain, or end-of-life doula, this kit supports your work. And for family caregivers listening, it offers gentle, trustworthy guidance to help you care for someone at home and feel more prepared for what's ahead. BK Books offers quantity discounts for teams, agencies, and families. So visit bkbooks.com to explore the Approaching Death Support Kit. See the show notes for this episode for a link to bkbooks.com.
Okay, so the hard questions, that's your thing, that's your jam, and you're really good at it. But what's a question that you hate to ask?
Have you completed your advance directives?
I would hate for you to ask me that one myself. But why do you hate that one so much?
I think because and I should say it's a tie between that and if your heart stops, what would you like us to do? That's
Right.
the other one I don't like. And the reason I don't like them is because we come into a space where we have no relationship with someone and we ask them a question like that and we expect them to give us an answer on the spot. Generally it's kind of like, what would you like us to do? And one, I always joke with people and I say, if you walk in and ask me if your heart stops, what do you want me to do? I'm going to say your job, right?
Sure.
Because you've given me no context. You haven't told me why my heart stopped. Did it stop because I had heart failure?
Right.
Did it stop because I got hit by a bus? Those are two different things, right? If I got hit by a bus and my heart stopped, you could possibly revive me and set all the broken bones and I could survive. If I have heart failure, it is exactly what the word is. Heart fails. There's no coming back from that. And so going in and asking a question like that, I just hate it because I feel like there's no relationship. It's kind of like getting married and never dating, right?
Yeah.
Exactly. And so I'm going to ask you a life or death question just on the spot without ever having talked to you about anything else. So other than maybe casual introductions.
Well, and such an intimate thing. And if you're the caregiver at the bedside and you are the one that's receiving this question, well, of course I don't want my person to die. Of course I want you to do everything. That's one of those phrases that I really wish we would stop. Don't say everything. Nobody knows what the hell that is.
Right.
Nobody knows. Even we don't know. I think a lot of times we use that term because it's faster and it's more convenient for us. Because the more I have to explain it to you, the longer it takes. And that means I have to stand there, watch your awkwardness and your grief and your misunderstandings, and maybe deal with my own awkwardness and secondary grief while I explain something to you that's super complicated you're probably not going to get. And I might not like your answer.
Right.
Because I don't agree with you. Yeah, I can see how you wouldn't like that one. Well, what's a question that you love to ask?
That's easy. What does quality of life mean to you?
Why do you like that one so much?
Because I think that's what all of this is about. I think when we're having these conversations about illness, wellness, sickness, in the end, that's what it's all about, the pursuit of quality of life. Quality of life, just like pain and anything in our lives, it changes. It ebbs and it flows, and we have to adapt and we have to change to it, based on whatever's going on in our life. So the question that I may have been asked 10 years ago about quality of life is completely different than the answer I might have 10 years later, based on what's going on in my life and everything else. And I love hearing the range of answers. I love the shock of people when you're asking it, because no one asks it.
Yeah.
No one sits down and asks them, like, what makes your life important? What brings quality? What do you love so much?
Yeah. What matters
And
to you?
right, exactly. And so when we're talking about quality of life, we usually will associate that with living in a nice house, driving a nice car, being in a good neighborhood, all of those things. But we don't take it down to the basics, which is what it really should be, is the fact that all of those things are done in an effort so that we don't suffer. And really, that's what it comes down to in the end. People don't want to feel pain. They don't want to suffer. They don't want to feel isolated. So I think in the end, that's what it comes down to. It's just you have to help them navigate and tease out everything else so they realize what's most important to them.
And what an important job and a meaningful job to be able to have, to help people say, it's important to me to be able to get up and walk to the kitchen because I want to be able to have coffee with my wife. That's quality of life for me.
Yes.
And we get to witness this and hear these conversations. This is why we still do this work after years. Yeah. Yes. So you work as a quality of life navigator. How are you supporting patients and caregivers in that particular role?
So quality of life navigator, it's interesting because if you search, you're not going to really find it.
No.
The quality of life navigator came up because I was sitting with a good friend who knows I just have so many tools in my toolbox, which functional medicine, holistic nursing, trauma and resilience, critical care, just all of those things. I'm an educator, at a university. And so she was like, so what exactly do you do?
Everything.
And it's kind of hard, to say everything. And so we were having this conversation about what do I find most important in my work, most meaningful in my work. And I said, I feel like I navigate people to understand what quality of life means to them. And so she's like, so you're a quality of life navigator. And it resonated. I was like, that is exactly what I am. Because strip away any formal roles, any credentials, anything else that I have. I think that's what it comes down to. And we've all that have done this work have the hard time. Like, I had a bad when I was working at one hospital. My jacket said palliative care, my badge said supportive care. And it was always a way to start conversation because the hospital did not want to call me palliative care. But my jackets were already embroidered, and I'm sorry, I am not going and getting new jackets. So I kept them both. And they would look at me and I could tell, like, why does it say two things? And I said, oh, you're probably noticing the mismatch. Well, medicine is a mismatch. And that's what I would tell them. Your heart doctor, doesn't call himself a heart doctor. He says he's a cardiologist. Your kidney doctor doesn't say that they're your kidney doctor. They say they're a nephrologist. So all of us have two names. What we are called by our credentials and what we do by our trade. So for me, that's exactly it. I'm a palliative care nurse practitioner. But when I'm outside of that formal role where, the board of nursing, board of medicine, everybody, what do I do? How do I relate to people? And so you asked earlier about keeping things completely separate. That was my way to keep things completely separate. I am a navigator. I can help you navigate through all of the quality of life issues you may have, but I'm not going to reach over on that other side and get into the medical side. And so that helps me keep it very clear. And I think that when people are reaching out or someone, makes a referral, a lot of times I'm working alongside, like aging specialists, social workers, other people that know me professionally, but also know me in the community and trust one that I am working purely on the behalf of that patient or family. I have no agenda. I don't work for an oncologist. Actually, right now, and I hate to use the word refuse because it makes it seem like I refuse to do it, but I refuse to do it because I want to look someone in the face and say, I don't work for a hospice. I don't work for a palliative care. I do work palliative care for a hospital, but they're contracting me to do that work as a palliative care nurse practitioner. But I don't even have a dog in that fight because I'm just in there to simply take care of their needs. So when someone feels like, okay, I understand what you do, there's no confusing title or anything like that. And what does that encompass? I don't know. What does quality of life mean to you? And then we'll explore what tools I have in my toolbox to help you achieve that. So I think that's the best way I can say that.
Well, I think the simplicity of that helps, right? It's narrowed and it's this one focus, which may seem small, but it actually influences everything else. Every decision that's made, every medical treatment that a patient or family decides to embrace or refuse. Yeah. So I want to talk, we don't have a whole lot of time left, but you've experienced a lot of loss, both personally and professionally, which we know shapes us, right? It impacts us. Tell me about a death that impacted you as a nursing professional and an end-of-life doula.
I think the one that always sticks with me is I had a patient. It was a very complicated case, and she was with her partner for years but had not married. Advanced directives were not completed. The family was in struggles with the partner. So it was a pretty complex case. The patient did not want to tell her partner that she knew she was dying. I mean, it was just like anything you could throw in there was thrown in there. And it became very evident that she was declining. And this case challenged me in so many ways. One of the ways it challenged me was that I had in consultation with the intensivist, the pharmacist, all of us agreed this patient needed some morphine, which we all know guidelines say is the gold standard for dyspnea at end of life. And I had ordered it up and said, for dyspnea. And then we had the scale. The patient requested it. The nurse on the shift said, what's your pain level? And the patient kept saying, that's not what it's ordered for. The nurse practitioner wrote the order for this. And the nurse told the patient that clearly the nurse practitioner doesn't know what they're doing because morphine would actually depress her respirations, and all of the people in hospice and palliative care are cringing and shifting in their seat like I'm doing right now.
Yes, I have a horrible feeling about this myself.
And so it became this battle, first of all, professionally, of being questioned in front of the patient, because when I walked in, the nurse let me know, she was coming off shift, that I needed to figure out what I was doing. And so I printed off some guidelines, you'd be happy to know, and handed them to her and said, since you're coming off shift, you might want to read these. But the point is that the patient should not have had to advocate so strongly for herself and then be made to doubt what was going on with the team. So that's the first thing of why this case, really stuck with me. But finally, there became a push to get her out and go to hospice. But it became very clear that that was not going to happen. And the only thing she wanted, she never had children, was to see her dogs. And, she just kept begging to see her dogs. Her partner is crying, the family's crying. And I am trying so hard to get these dogs in the hospital. And I was met with bureaucracy that was saying, well, are they service dogs? We can't have anything but a service dog. And all of this stuff happened. And while we're doing all of this, she did pass away. And the nurses themselves were coming to me going, why couldn't you fix this? And they're crying and I'm crying because I felt like, why am I doing what I'm doing if I can't fulfill a single end of life wish? So that one, it stayed so pierced because it showed the complications of dying within the system in a hospital.
Yeah.
And how complex it can be, and how it's not just as simple as asking questions about advanced directives and who's going to make your decisions and what do you want at end of life. Had we known that her dogs were important, maybe we could have gotten before the hospital administration, and we could have done something. Even if that was somehow get her even to the lobby so she could see her
Right.
dogs, but there was no time because those conversations did not take place. So professionally, I would say that was probably one of the hardest ones that I experienced in all the years that I've been doing this.
I can see why that sticks with you. And I think probably every hospice worker, end-of-life worker has a story like that. And there are a lot of lessons to be learned from it. But sometimes those lessons are heartbreaking and not in the best interests of our patients. Sometimes we learn at our patients' expenses, which is exactly what happened when the nurse went to the patient and said, your nurse practitioner doesn't know what she's doing, which was highly inappropriate, horribly inappropriate. And can you imagine being the patient in the bed and being told, oh, the person who's taking care of you doesn't know they're behind from a hole in the ground?
Correct.
Yeah.
Correct.
Not helpful.
Never having known that this was a consultation, with a team that had agreed, this is probably the best course of action right now for us based on all of the other things that were going on. We prioritized that was more distressing to her than any other symptom that she had.
Yeah.
To have somebody who was outside of that undermine it was very difficult. And people need to realize when they're having conversations, they need to always, like you said, we can't show our, whether we agree or disagree with the decision. It's best to go to the team and say, I'm a little confused. This says it's ordered for respiratory.
Right.
So as a nurse practitioner, one of my physician colleagues had come up to me, and because I said I had printed off the guidelines, and he said to me, when I told him that, he just looked at me, he goes, that's the difference between you and me. I would have said, if you want to act like a provider, go look up the guidelines. He said, I wouldn't have made it easier for her. He said, you have board certified in your specialty, and you consulted with the appropriate people on the team, and you should not have second guessed yourself. And so that was yet another very important lesson that, have confidence in the knowledge that you have, especially when you're consulting with the rest of the team.
Well, so I would push back on that a little bit. I get what he's saying, but he's also maybe being a little bit arrogant in that particular way. What you did was give her a chance to educate herself. Here, you might want to learn about this in a way that's a little more respectful, so she could go off and lick her wounds and realize, I made a mistake and I should not. Now, the fact that she presented it to the patient is a whole different conversation, but to respect each other professionally, I think is super important.
Agreed.
And not everybody has training I don't want to say sensitivity
Yes.
training, but not everybody feels that way. And I am of the school of thought, because I've worked in hospice for so long. We are blessed with this interdisciplinary, multidisciplinary mindset. There's no hierarchy. I know something the
Yes.
doctor doesn't know. He knows something the social worker doesn't know, who knows something the chaplain doesn't know, who knows something we all don't know. You know, we bring these skills, and nobody is not essential to the care of the patient, but we are all learning. So, okay. How can listeners find you as a quality of life navigator? I love that term. How can they find you, work with you, see what you're doing, and check out your services?
Well, my website is currently up, Tree of Life Health Consultant. And so it's just that.com. Trying to work on it. I'm not in love with it, but it does have the essential information. I'm really active on LinkedIn as well. And I have a Facebook page. They can just reach out to me, and I'd be glad to sit down and talk to them, kind of get a. I think once again, we come down to communication and relationship. I would like somebody to sit with me for 30 minutes and just kind of talk and say, okay, let's, this is going to be a relationship. Let's see if it's going to work for us. Is this a style that's working for me? And it's not personal. And I guess that's the nice thing. You're not assigned somebody, right? You
Right.
choose somebody. So I think that starts the empowerment from the beginning, that they are reaching out and saying, I need some help. I need somebody to help navigate, to support me. One of the things that I'm going to be adding to my toolbox that I'm very excited about is digital therapeutics or immersive reality. And there again goes with that quality of life. We've got people who are homebound. It's all great to tell somebody, oh, you only have a couple of months. You can go to Italy. No,
Yeah,
you
you can
can't.
do whatever you want to, except you can't.
No, you can't, because you're on oxygen and you need an aid, and you can't leave the country, and so many other reasons. And then it's great to tell the caregiver, take a few minutes for yourself. Where?
Yeah,
When?
that's not
Um,
realistic for many
so
people.
I think we have the technology to sit down and get somebody a session where they can go to Italy. They can, if for a veteran to be able to go and visit the World War II Memorial or the Vietnam Wall.
Yeah.
For that person who never got to Tahiti or wherever it is that they wanted to go, and give them a few minutes, of sitting down and improving that little quality of life. The VA has done a lot of research, and VR has been shown to lessen isolation pain, and so I think using the technology we have, we can help people improve their quality of life, by doing things like that. So that's one of the things I'm very excited that I'm going to be rolling out soon.
Nice, nice. Well, I will have links to your social media and to your website in the show notes, but it's treeoflifehealthconsultant.com.
.com. Yes.
Elena, thank you so much. You're going to have to come back, This was a fantastic
Oh, I'd
conversation.
love to. Thank you. Thank you so much. Thank you for having me.
Thanks for listening to the Heart of Hospice podcast. Check out our sponsor in the show notes, and please leave a rating and review on Apple Podcasts. We would appreciate it if you would share this episode with your friends and family and anyone who needs to know more about hospice. Connect with us on Facebook, Instagram, and LinkedIn. And remember, no matter who you are or where you are in your hospice journey, you are the heart of hospice.
This is the Whole Care Network. Helping you tell your story one podcast at a time.